Hey guys, welcome back to the Foam for At podcast. Tyler and Sam, we're talking about counterpulsation therapy, augmenting diastolic pressures with the balloon pump. And so I had on the one and only Brian Cress, perfusionist extraordinaire. We brought up some graphics, some diagrams, and discussed it. I'll preface this by saying I was not feeling the best when I recorded this.
You
I
look
had a
like Nick
cold.
Lachey trying to dodge the paparazzi in this episode.
Dude, my hat was on and then you couldn't see my eyes. I hated it. I almost thought about scrapping it, but I'm like, oh, the content was so good. And it was already our second time recording it because the first time his internet went out. So, yes, I look like somebody trying to dodge the paparazzi. My hat's on. It's even like a little bit crooked, and I didn't even notice that until I was watching it. So, don't look at me. Just listen to it. Look at Brian Cress. But Sam, you listened to the episode. You had some thoughts on the map and stuff. So let's do a little primer before we get into it.
Yeah, when and you can edit this in post. The second graphic that you use that's actually looking at the balloon pump and the user interface screen. And I'm sure we'll pop it up right now, but I have it pulled up over here. My brain, just to like preface everyone's brain on how to read this and just a few of the numbers, because some of it seems a little bit counterintuitive. So my brain immediately wants to read the pressure on the top right is 99 over 114 and 49 over 56. And then your brain is like, well, I guess the diastolic augmentation does raise the diastole. Is that the way it's supposed to be? But it's big numbers go together and small numbers go together. And so once your brain starts dissecting that, like this is what my brain did was I wrote these down. So the unassisted is 114 over 56. And so if you were to calculate that map, it would be 75. And this is just to also say like there's one assisted beat, one unassisted beat. So you have like every other that's going on. So that's why you have two sets of numbers there. And so the unassisted 114 over 56, map of 75. And then you have the assisted, which is 99 over 49 for a map of 65, right? And so if you average those out, it'd be like 70-ish, you know? And that might make somebody, if they're unfamiliar with balloon pumps, immediately think like the assisted ones are lower. The systemic pressure looks lower than it does when it's unassisted. Like the unassisted is, you know, the systolic and diastolic are higher. But the whole point of the assistance is to take workload off of the heart. And then you get this diastolic augmentation that you guys talk about. And that's the number that's built in, which is that 86 down there. So I don't know exactly what formula that they use. But again, if you were to average out unassisted and assisted solely, it'd be like 70. But because of that big diastolic augmentation peak that goes in there, that gives you the actual map of 86. And so that's, I guess, those two things. Like the assisted one looks worse, but it's actually not, because you have to factor in the actual map number below, which is with the diastolic augmentation. So I just think like figuring out that math in your head, like you don't want to get led astray by kind of the actual numbers on there, but you like it seems like the best one to pay attention to is pretty much that map down there, until you guys are talking about the difference between the highest point and the lowest point for the diastolic augmentation.
Yeah, and you know, one of the things that can be confusing is you look at that diastolic and you're like the assisted diastolic, and you're like, wait a second, 49. That's way lower than it should be. That should be higher.
Mm-hmm.
And it's because you're measuring 2 points of that diastolic phase. You're measuring the very maximal impulse, and then when it deflates and it leaves this void and it creates that, you know, we say it's kind of like a kiss suction effect to offload the LV. That's why it drops down. So you're seeing that the beginning of the diastolic period and the end of the diastolic period. Yeah. And the other thing you and I were discussing is, you know, we always think about this stuff from, you know, you have a pressure sensor that's trapped between an inflated balloon and a closed aortic valve. And so you see this big spike with that augmentation. But if you think about what's happening below the balloon, you know, going down and like you mentioned, like the renal circulation, you know, the descending aorta, it's still seeing that same thing because you're displacing that blood that way as well. And so you and I went down a rabbit hole yesterday being like, does it inflate from the bottom up? Like you said, like a syringe pushing it into the coronary arteries, or does it go from the top down? And it looks like it's kind of simultaneous the way they have it designed.
Yeah, just like
it
all
inflates,
at once.
Yeah, you really. So Sam sends me a message, and he's like, it had this thing he looked up, and he typed it out, and I think you were asking ChatGPT or something, and it
Yeah.
said the sausage inflates at one, all in one, and he's like, I did not say
Yeah,
sausage.
I'm like, where did it put sausage in quotation marks that the sausage inflates all at once? And I'm like, I'm sending you this screenshot, but I want you to know that I never referred to the balloon as the sausage that's in the
I'm
aorta.
adding
And
that.
I'm like, I don't know where it pulled that from. But yeah, like if you have a femoral line, because I think with balloon pumps, that pressure sensor is between the tip of the balloon, and it's kind of go like before the left subclavian. It's going up into the aortic arch, and so it's going to look a little bit different because like above the balloon versus below the balloon. Because above the balloon, when that blood is displaced, like it's going against a closed aortic valve, so it's kind of hitting this like hard stop, which is cool because then it's like diverting off into the coronary ostia and perfusing the heart. Like that part's awesome. But I was wondering about below the balloon, and I was thinking like it's a little bit different down there. You're probably not going to hit as high of a pressure peak, but it is like just suprarenal. So that pressure peak actually might really be helping the kidneys as well. If it's inflating all at once, like you might get a little pressure spike going into the kidneys. So that's good. But if you're monitoring it from a femoral line, it's a little bit further away. It's almost like an art line, how you see like if it's in the radial, you see this like nice, or if it's in the subclavian or something like that, you see like the dicrotic notch really close to the peak pressure in the A line. And then when you back out further to like a femoral line, it's a little bit wider, it's a little bit further away because that wave has had time to kind of like reverberate out. Just like you drop a drop of water and you see like the peaks are like really high
Mhm.
and frequent close to it, and then it kind of evens out as it goes through. So with your femoral line, you might see not as high of a peak because it's had a little bit of time to measure out. And that could change your map a little bit from what the balloon pump sees to what the femoral line actually sees. But it is kind of reassuring to think like, with balloon pumps, you really only think about the stuff that's going on above the balloon where you're monitoring that pressure. But it seems like it gives the whole system, like top and bottom, a pressure boost, which to me, like reinforces that map number on the balloon pump itself as being like a good number to monitor for.
Yeah, and that's one of the things that like the program I work with, like LifeLink 3, they really stress like watch the map on the balloon pump just
Mhm.
because of exactly what you said. It was funny when I was recording with Brian the first time, I was like, yeah, what do you think a radial art line would look like? And he's like, well, it's seeing the same pressure as like what the coronary arteries would see because it's still just coming off of that, it's still above the balloon. And dude, in my head, I was thinking before that, I'm like, oh my God, duh, that makes sense. But I'm thinking like your hands are down here, So I'm like, oh, okay, is it going to throw it off? But afterwards, he's like, do you want to cut that out? I'm like, no, that's good. Keep it. Because if you're not thinking about where they're originating from, you could think like, oh, okay. And maybe a radial does look a little bit different because it's just, further away or if they have
Mhm.
peripheral vascular disease, whatever. But yeah, it is seeing the same thing. And I thought when I first started learning balloon pumps that the pressure sensor at the tip was the art line, right? That was your art line. And then that's what everything was going off of. And so what I realized is that most of these are fiber optic. So there's no zeroing, there's nothing like that. And then if they do want to switch it to a art line or whatever, they can just use a peripheral art line. They don't have to use, and they rarely use. I guess this is probably institutionally, I don't know, variable, but they rarely use that art line that's actually on the balloon.
Mhm.
They'll use a peripheral one before they will use that one. So I thought that was interesting too, because I was like, I did not know that. But usually it's that fiber optic cable.
Yeah. And I just don't think before this interview with Brian, like and looking at these numbers and like really thinking about assisted versus unassisted in the map and stuff, I don't think I ever really gave much thought to like what goes on below the balloon
Hmm.
ever. So, but I think that
No,
the
yeah.
femoral line is an interesting concept. I was trying to look online to see like examples of a femoral line at the same time as the balloon pump is going with its fiber optic, and I couldn't find any examples. But it'd be cool if any listeners have some like good cases on that of like differences between those two, it'd be really interesting to look at.
All right, well, let's roll on with the interview.
Let's roll it.
Yeah, I wanted to pick your brain, Brian, because, we occasionally will transport a patient on a balloon pump. It's not all the time, a few times a year. And I wanted to talk about really optimizing the diastolic augmentation and what's too high. And somebody asked me in a class I was actually teaching with Dan Rao, a critical care class. They said, what's the target, And so to get into that discussion, I thought maybe you could just give us a foundation of coronary perfusion, the importance of diastole, and then we'll work the balloon pump into it.
For sure. Absolutely. Thanks for having me. I really appreciate the opportunity to be here. So, so the balloon pump is primarily a device that's used for a cardiogenic failure, cardiogenic shock type situations where the heart is the issue. And to kind of understand how it works and our limits with it and what might be too much or not enough, we kind of have to understand, like you were talking about, the basics of coronary perfusion, which is the goal of the balloon pump. The primary goal is to increase coronary perfusion. And it does that through a diastolic augmentation is what it's called. And so just to kind of recap, and if you want to get a little more detail on coronary perfusion and pressure, I've got a blog up with foam frats called Under Pressure. It's a good read. I think you should check it out if you haven't. But just to kind of recap that, so basically what happens is when the heart is in systole and squeezing blood into the aorta, that myocardium in that muscle gets really tight. And what happens at the distal end of those coronary arteries is the heart actually kind of squeezes down on them. So you have this increased resistance and this pressure at the distal end of these coronary arteries. And so blood's not really able to move into that space with such a high pressure there. So that's part of the reason why we say that the heart's coronary arteries fill during diastole. You do get a little bit of filling into the coronary arteries from the eddy currents that occur around the aortic valve when it's opened, but there's really not much that you can do if the pressures are equalized on both sides. And if you kind of think about it, what I'm pushing out of the heart must equal the pressure that we're getting in the aorta, right? Because that's how the pressure is generated. So, long story short, the heart coronary arteries, the coronary arteries are perfused mainly during diastole, and that's for two reasons. One is that the aortic valve closes, and then the blood that's in the aorta really has no other place to go other than to the distal tissues, and so we see that being perfused into the aortic arch, into the distal femoral tissues, and further down below. But also we see the blood kind of encountering that aortic valve as it's closed, and then being kind of pushed along to the sides to where the coronary ostia are. And so the other part of that is that the heart muscle itself is relaxed. So we don't have this super high tension at the distal ends of the coronary arteries. And so with a lower pressure, there's less pressure needed to push it forward in order to perfuse those tissues. And the surrogate that we use for that, if you have it available, is a pulmonary capillary wedge pressure, or a PCWP. And that's a loose correlate to the actual value that we're looking at, which is called left ventricular end diastolic pressure, or LVEDP. And we want that number to be lower. We want that end diastolic pressure to be as low as possible so that the atria can kick blood into the ventricle without meeting much resistance. And then also the coronaries can fill without much resistance. So when we have an issue with those things, then we have an issue with coronary filling. And that's kind of what the balloon pump is hoping to address.
Yeah, so that left ventricular end diastolic pressure, or your wedge pressure, that's the pressure inside the left ventricle at the end of diastole. And
Correct.
the reason that's important is because that is the counter pressure that we have to overcome as we are filling the coronary arteries. So big LV, tons of blood because it didn't get ejected out, means you're going to have more resistance. In your Impella class, you said it's like, a 400-pound person putting on skinny jeans and trying to put their hands in their pockets. So that's the problem, right? So now we start to work into let's say somebody has some plaque that ruptures. They have a lesion, coronary lesion, and maybe it's multivessel or whatever the case may be. But we need to optimize that perfusion. The problem is if you were to try to optimize and really increase that diastolic pressure with things like pressors and levo, epi, or whatever, then you're also making it hard for the LV to eject that blood out because the left ventricle has to overcome that pressure. And so that's where the counterpulsation therapy, the balloon pump, comes into play because we can change the dynamics throughout the cycle. So walk me through what the balloon pump does.
Yeah. And to just touch up a little bit on what you're saying, you end up in this spiral where you have this lesion that knocks out a wall of the heart. It's not able to squeeze as effectively. So you end up getting this increased pressure inside the ventricle, and then that further increases the resistance that's within the coronary arteries, and then you start seeing lower coronary flows in other areas of the heart. Then all of the walls start to get knocked out, and then anything you do to increase your diastolic pressure is also going to increase any medications that you use to increase your diastolic pressure is also going to increase your systolic pressure and your afterload. Right? There's no diastolic-only blood pressure medication, unfortunately. But yeah, so exactly what you were saying, you end up in this spiral. And what the balloon pump helps or hopes to do or does do with its counterpulsation therapy is it takes the balloon size, which could be 40 cc's or 50 cc's. Those are the two most common. And it will displace that same amount of blood. So it sits inside of the aorta and the descending aorta just below the left subclavian artery. And as it inflates, it kind of displaces that blood both up and down. Now, most of that is hopefully going back up into the aortic arch, back toward the heart, but obviously you do have a little bit of blood being pushed down as well to the femoral arteries. So by pushing that blood back up into the aortic arch and into the aortic root during diastole, you end up with this increased pressure during diastole. So it's not a medication, but it's using counterpulsation to increase the diastolic pressure that you have during that diastolic phase. And it's important to note that the balloon pump only is going to work if you inflate it during diastole and you have it deflated during systole. And to touch on that a little bit, an added benefit is you kind of get this decreased afterload effect with the balloon as it deflates as well. It's not really truly a suction effect, but I think you said as we were talking earlier, prepping, it's kind of like almost like a kiss, right? Like a little bit of a suction kiss right there that will help decrease the afterload and the resistance that the heart has to work against. So that's the general concept behind the counterpulsation.
Yeah, and I think about when it deflates, it's going to leave a void in the aorta, and you can't have a void in the aorta. So the blood has to come from somewhere, and it can come from the ascending or descending portion. Right. And so that's why at times right at the beginning, right before systole, so that way it hopefully is going to fill that with blood from the LV and then offload that and then optimize the diastolic perfusion on there. And so I have I'm going to share my window here because I have a graphic that I want us to look at. All right, so can you see this?
Yeah, I can. Yes.
All right, so this is an augmented diastolic over here versus just normal. And so the reason I like this is because when we think about a diastolic pressure, we think of just a single number, 120 over 80. Oh, okay, 80 is my diastolic. But us talking offline a little bit, you pointed out that, that 80, that's after it comes all the ways back down, right? So right when the aortic valve... Yeah, right when the aortic valve closes, you get this little backlash, of blood that brushes up against it. And you have this fresh column of oxygenated blood that has been ejected into the, arterial tree, the aorta. And so as this starts to go down, that's just the blood distributing through the tissues and through the body. But what I like about this graph is this is the LV pressure, and you can see that in the very beginning phase, like right when that aortic valve closes, we still have a pretty good amount of LV pressure. We haven't really gotten to that lusitropy relaxation phase until further down. And so what I like about this is when I initially looked at it, I'm like, well, why are they continuing diastolic perfusion all the ways to down here when it's really just the here? But it's because this ventricle relaxing is allowing more perfusion. And so if you were to average out the pressure in the actual coronary perfusion, you get this mean diastolic filling pressure. And so when you move to this one, and you can see this is when the balloon inflated, right, right as that aortic valve closed, we get this nice sharp spike here. And now the diastolic pressure is the highest pressure throughout that cardiac cycle. So anything you wanted to add to that? I just wanted to bring this up because I think this is a helpful illustration. And well, yeah, let me say, I'll ask that. Is there anything you want to add to that before I ask you the next?
I'm really glad you brought the graphic up because there's a couple things we can talk about this, and it's important to think as you were talking about, the numbers are not just numbers, right? Those are averages or the lowest or highest impulse points, right? So you've got to really think about what's happening with the pressure under the curve, right? Just like you would talk about with your airway pressures. If you're trying to optimize ventilation, you need to increase the time under the curve that's being oxygenated. Same thing with this. And we talked a little bit about LVEDP. And if maybe you can do this with your editing magic, if you can trace the line that's falling from the left ventricular pressure and it goes all the way down almost to zero, that's the LVEDP that we want to see, right? That's a low LVEDP, which allows a lot of distance in between those two lines, the diastolic pressure line and the LVEDP line. And the bigger the gap there, the more pressure you have and the more filling that you have, right? So if you were to imagine, you can take that LVEDP line and move it up a little bit to simulate an increased LVEDP, then you would have a lower or a smaller area of red, a smaller area of perfusion. Does that make sense what I'm saying?
Absolutely. Yeah. I can't animate that right now, but yes.
Right. No, of course. Yeah. And so you can even see that in the next picture or in the next waveform over. Instead of decreasing the LVEDP, which would essentially do the same effect, you're starting at a higher point. You're starting at a higher point of pressure during diastole, and that naturally allows there to be more area under the curve, and so you end up with a lot more red or a lot more perfusion, which is what we're looking at there. So I'm glad you brought that up. And then I also see something else on this graphic, the diastolic filling index or diastolic filling pressure index. And it's important to remember that nearly everything in our bodies can be indexed to a standard versus, how we as a human being present. And what I mean by that is my heart rate and pressures are not going to be the same as your heart rate and pressures because we're different sizes, but indexed together, we could both be normal. And so it's important to note that with that ventricular filling or that diastolic filling index, that can be affected by rate as well. So if you end up in a significantly higher rate, 140s, 150s, 160s, you're looking at like an SVT kind of thing, that area of perfusion or that time that perfusion is allowed to occur will actually decrease, right? Because normally in our bodies, you've got 1/3 of a systolic phase and 2/3 of your diastolic phase in your cardiac cycle. That's the typical teaching. But that obviously changes as you increase or decrease your heart rate. So if you get into those super tachycardic rhythms, you are going to end up, even if you have the higher pressures, you're going to end up with less filling and less coronary perfusion.
Yeah, and that was going to be my next question, is because typically when somebody is in a cardiogenic shock state and when they're getting a balloon pump, they're going to have this compensatory tachycardia. And, my thought is once they're on a balloon pump, if they're starting to tick along at 150s, 160s, how effective is this diastolic augmentation. And so you kind of answered it there, because we are increasing, the peak, the pip of the
Yeah.
diastolic phase. We're hitting this higher, and so we have more time, but we have to, because we probably have higher left ventricular pressures, because
Right.
it's not able to offload as much initially, right? And then hopefully you start to offload it, and you see an increase in that coronary perfusion. But I was curious, how often do you see rate control to try to augment the diastolic phase, then try to optimize that diastolic period time index?
Honestly, it's not very frequent, and the reason being is because the balloon pump is pretty good at getting the heart, the oxygenated blood that it needs. It's obviously not going to be the answer to every solution, and it's not going to be the best answer to every solution, right? But for what it does and how it works, you see these patients come in with these massive MIs, multivessel occlusions, and they're not quite able to stent all of them, or if we have a hard time coming off bypass because the patient's heart is a little bit more sluggish after a cardioplegia, or maybe it's just the anomalous pathology of that particular um, patient. What we find, or what I typically see, is that after even 30, 40 or minutes or an hour on the balloon pump, their body will start to naturally um, recompensate, I guess you could say. They would stop the compensation by by slowing their heart rate down and all that naturally, because the blood is getting fed its own oxygen. But however, there are situations like you alluded to where you would have, a heart rate of 150, 160 or something like that. Perhaps they have an electrical arrhythmia that has nothing to do with um, a tachycardia that is ischemia induced. Instead, it's an electrical issue, and we see rate control medications administered in those circumstances, because you certainly want to try to extend that diastolic filling as much as possible. If you get into this situation where you're at just as much time to offload as you do to reload, then you end up getting into these significant decompensation situations.
Yeah, no, that makes a lot of sense. All right, I'm going to show you a picture here. Let me switch
Okay.
to this one now. So this is just a screenshot of the balloon pump control panel, or the interface, and I have two. Just because we're talking about the diastolic period, I have two of these marched out, or kind of blocked out. So 1 to 2 timing, we can see our unassisted and our assisted here. And I just wanted to go through what exactly we're looking at, because when I first learned about balloon pumps and I saw the display, I thought this was the pressure inside the balloon,
Mm.
like inside the actual balloon, right? So
Right,
I
right.
was like, wow, that's a lot of pressure. So what is this augmentation, this diastolic augmentation?
Yeah, so the diastolic augmentation, the 141, the number that you're seeing there, is the peak pressure during assisted diastole. So while the balloon is inflated and assisting the heart, that peak pressure where that left arrowhead goes to, that'll be that 141 number.
And I think the thing that could be confusing is you see unassisted here, and then you assume that this one is assisted, and you may be like, well, that doesn't seem like assisted diastole. That doesn't seem like it's augmenting anything. That's 49. That 49 is the assisted end diastole. So
Yes,
that's what you're taking that afterload down to
yes.
before this systolic phase of the next beat.
Right.
Do I got that right?
Yeah, yeah, essentially you do. Your unassisted diastolic pressures are going to be like your typical, what your blood pressure would be without the assistance of the balloon pump. But then your assisted diastolic pressures are going to be lower than that typical one, and and that's because of that, that kiss effect, I guess, essentially that little bit of an afterload reduction that you get with the balloon. But you have that correct, yeah.
So this number here is the augmented diastole.
Yep.
This number right here is the assisted end diastole.
Correct. You go from, so you have this swing from 141 down to 49. That's correct.
So those are the two numbers that I'm trying to optimize with this. And so I've seen you want to keep this one about 10 to 20 below what their regular diastolic period is, to take about 10 to 20 millimeters of mercury off of the afterload. But what about this one? This is the one I have a lot of questions about, because, I've seen some resources say 10 to 20 above what their diastolic is. But here, if their diastolic's 56, this augmentation, this augmented pressure is 141.
Mm-hmm.
Can the heart handle that? Is that too much?
Yeah, great question. So like if we were seeing a patient with a blood pressure of a diastolic blood pressure of 141, like without any sort of device, like we would be considering like they're stroking, right? They're obviously stroking or something. But it's not quite the same physiology with the balloon pump, right? It's important to remember that augmented pressure of 141 is only being seen for a split second at the tip of diastole. Yep, it's only for a moment. And if you think about it, 141 is really not that much pressure, because your normal systolic pressures can be 140. People walk around with 140, 150, 160 systolic pressure all the time. I mean, obviously it's not very healthy, but it's something that your blood vessels, absolutely, your arteries can handle, barring any other tissue disorders or other comorbidities that may be present. But it's important to remember, though, that pressure is at a temporary amount of time. It's relatively normal pressure that those blood vessels would see anyway with a normal systolic pressure. And on top of that, you don't have the systolic pressure that's 40 or 50 points above that diastolic pressure of 141 to cause that concern of, now we're thinking about stroking or whatever else. Now, if that number climbs up into the 160s, 170s, something like that, then yeah, I do think that you might want to consider decreasing the augmentation a little bit. And generally, when balloon pumps are run, they're run at full augmentation. And what that means is that the balloon is inflating and deflating with its full volume of air. So it's a 50 cc balloon. It'll inflate and deflate with 50 cc's of helium. If it's a 40 cc, et cetera, same thing. Now you can decrease the augmentation to say like 75%, and then a 40 cc balloon would only get filled with 30 cc's of air or helium. So by doing that, you decrease the pressure inside of the balloon, which means you're pushing less pressure into the aorta, which means you're going to get less pressure at the assisted diastole. Does that make sense? The way I described that?
Yeah, that's what I was going to ask. So 100% augmentation means you are filling up that entire balloon to its 40, 50 cc capability. So looking at the augmented pressure of 141, if it started creeping up, my thought would be, for one, if they're on pressors, should I start coming down on those pressors a little bit? Because if my native diastolic is increasing, my brain is going, they might be getting better, right? Or it could be maybe my pressors are just way too high, and I'd much rather get that diastolic up with the balloon as opposed to having them on, crazy high doses of something like Levo or Epi or whatever that are going to cause the tachycardia, which is going to decrease a DPTI as well. Yeah. So is that the right thinking, that if I start seeing that augmented pressure coming up, before I go and start trying to dial down my balloon, maybe I should take a look at my pressors?
Absolutely. Yeah, that's it's not uncommon to see patients on balloon pump and pressors, but it's also not common to see the pressors starting to be weaned after the balloon pump is active, as long as the rest of the body can support it, right? Because the pressors are also help supporting the kidneys slightly, with end organ perfusion and whatever else. They can do harm, certainly, if they're too high, which is kind of why we want to start to reduce it. But if you have a fantastic diastolic augmentation and your heart is seeing, the numbers like you have here on the screen, an augmented pressure of 141 and a map of 86, that's great. But if the rest of your body is seeing a map of 40, then, that's a problem for the rest of your body. So you've got to consider that as you start to wean other pressors and things like that. But you will definitely see a benefit as you come down on the pressors. You're going to see an even more enhanced effect of the balloon pump.
All right, let's talk about goals then. So I have this set. I'm like, cool, these numbers look okay to me. Brian Cress said that they were fine, so I feel comfortable with this. But I want to look for ways of knowing that the patient is getting better,
Yeah.
and so there's ECG, there's ultrasound, maybe they have a swan in. It's not like we're going to do a wedge and transport, but is there
Right.
some non-invasive ways that we can evaluate this?
Yeah, absolutely. So, an ECG is probably going to be one of the least reliable methods to determine whether or not your balloon pump is working. Certainly, you can have arrhythmias due to ischemia that do get better as the balloon pump is put in, and that can't be a measurement of success. However, it's also possible that your electrical system is just fried and independent of what ischemia is or isn't there. So I wouldn't rely on an ECG to determine whether or not the balloon pump is working. You mentioned ultrasound, and in the hospital they've got amazing ultrasounds that you can measure things out to the millimeter and calculate ejection fractions and things like that. I don't think a lot of folks are probably doing that in the field, but you can just simply look at the heart and say, before it was full and round and looked like a basketball, but now I'm seeing wall movement and now I'm not seeing so much blood in the ventricle after systole. So just kind of a visual trend. It's a bit of a subjective trend to determine whether or not the balloon pump is working. So that's one way you could look at with ultrasound. And that, yeah, like you said, I don't think many people are going to be wedging during transport. Um, but you can kind of just look at your PA catheter numbers and start to see the trend in those as well, because as you start to get less resistance downstream from the PA catheter, your whole of PA catheter numbers are going to change as well. And so as you've seen improvement with those numbers, you can somewhat correlate that to whether or not the balloon pump is working. As long as there's nothing else that's been changed, pressors or anything like that. As long as nothing else has been changed, then I would say that that's a fairly reliable way to look at it. If you can wedge the patient, that would be great. You could do that, but
Don't do
um,
that. Don't do that.
okay. Oh, sorry. Okay, don't do that in transport. Yeah.
Yeah, do not do that in transport. Big disclaimer. No, I think that looking at I like looking at a parasternal long view and then looking at how far the mitral valve is from the septum at its upper inflection, because that really gives you a good idea
Yeah.
of the ventricular offloading and
Yeah.
then how much pressure is left at the end of systole and before that next contraction, because you need that pressure gradient for the blood to flow from the atrium to the ventricle. So
Yeah.
looking at that little flap, and if you see that you're offloading that ventricle, I mean, that's a very good thing. That means you're augmenting it and you're decreasing that opposing pressure. The other thing I just wanted to say real quick too, I was thinking about this earlier, yes, tachycardia is kind of counterintuitive to what this is doing. And before, I think I would go down the role of should I try to rate control? If these patients are intubated, think about the fact that they could have a lack of sedation or
For
pain
sure.
medication, all the other things that can cause tachycardia. It's not, just a compensatory, but still
Yeah.
think about all of those other things as well.
That's a great point because the balloon pump's not an end all and save all for this, right? So every other assessment that you would normally be doing and every other treatment modality that you would be doing, you still have to do. The balloon pump is simply going to help augment the diastolic pressure in the aortic root so that more blood can be delivered to the coronary arteries. That's all it's doing. And to hope or wish for the balloon pump to save more than that, I think is setting it up for failure. But it's very good at what it does, for how it is designed and placed. It doesn't need to be placed under fluoro or anything like that. It can be placed in an emergency room under ultrasound and confirmed with an X-ray. So it's a very relatively cheaper device, that's accessible to many areas, including critical access hospitals, or community hospitals, and it's it does a really good job at the one thing that it does, but it's not a save all for the patient.
Yeah, let's real quick before we end this, let's hit on the concept that most of these are fiber optics. So we don't need to be
Yeah.
doing zeroing. We're just basically plug and play. It's set to go. However, they may have a radial art line in as well. So what am I charting? What pressure? Am I charting the one on the art line? Am I charting the one on the pump? What does that look like?
Well, always follow your documentation guidelines and policies. However, I'll give a little bit of tidbit information here. The fiber optic sensors aren't really true transducers to atmospheric air, right? They have a sensor in them. They're internally calibrated, which is good, but you can't zero them like you can. I mean, you can zero them internally, but you can't physically open a stopcock to air and zero it that way. And so while the pressures may be extremely similar and accurate, if you have a radial arterial line, that is the one that I would recommend documenting for your patient's blood pressure. Not only because that's probably the more accurate one, but also because that's the one that your distal tissues are probably seeing as well. So that's probably the better one to document as far as that goes. Obviously, there's some numbers that you're only going to get off of your balloon pump, like the diastolic augmentation pressure, and your assisted and unassisted pressures, the differences between those two. You can only get off of the balloon pump. Now, if you didn't have an arterial, or like a radial arterial line or something like that, the balloon pump numbers, I've charted them. I think that they're reasonably accurate, and there's no issue with those as well. As far as if that's your only access in line. And it's important to remember that usually your radial and your balloon pump waveforms are going to be pretty similar, a little bit lower on the radial side, just because as distance from the point of pressure, as distance increases from the point of pressure, you get more resistance just from the walls of the vessels. But if you have a femoral art line, that number is going to be somewhat different than your radial, just because of its position below the balloon. And so you might see a little bit of a lag there, or the numbers might be even lower. So if you had a choice between charting a femoral arterial line and a balloon pump, I'd probably lean on the balloon pump, because that's where your head vessels are going to be, that's where your heart vessels are, and I feel like that's probably the more accurate number in those situations.
No, perfect. Here's a weird question.
Yeah.
Because the diastolic phase is going to be the highest number, is that going to throw it off when I plug it into my Zoll and I'm looking at it? Does it show that the augmented diastole is actually the systolic?
I literally was thinking that as I was saying it. I'm like, I wonder if, and I can't remember. Maybe one of the listeners can chime in if they've done a recent one. And I don't have like access to the Zoll monitor anymore on these balloon pump patients that I have. So, and I'm trying to think, if I look up at the monitor, I guess I've never really paid attention to it. I
I
think
don't know if I have either.
that's a good question. I think it would. Like, if your monitor is set to just read the point of maximal impulse and the point of or pressure and the point of lowest pressure, I think it would probably read those.
So it's probably just best to go off of your map at that point.
Yeah. Yeah. Or like I said, or the balloon pump, you can look at the screen, and if
Yeah.
it has an assisted and unassisted. I didn't mean to disparage the balloon pump's waveforms when I said it's not really truly like calibrated to atmospheric air, and it's zeroed and calibrated internally, and the numbers are accurate. And I'm sure whatever method that they do it by is sufficient and adequate. Otherwise, obviously, we'd be having a lot more problems than what we do. So I think
No, that's
no
not
matter
what
what
I
setting
heard.
we're
I heard you say that it was terrible.
no. Yeah. Well, at least I didn't say a manufacturer. No, I'm just kidding. But
Um,
yeah.
No, the other thing I was going to say is because the majority of these are fiber optic,
Mhm.
there's also on pretty much all the ones that I've seen, there is a hookup if you wanted to connect a transducer to the arterial line bifurcation where it comes off. You could, but I don't see
Right.
that done that often.
Yeah.
And so we were talking yesterday in the event of a fiber optic failure, would you run the art line off of the radial art line or the femoral art line, or would you connect to the one on the actual balloon?
Like if you only had one option to plug into your monitor, would you rather do it off the balloon pump or the radial?
Yeah, yeah. I mean, you can trigger it off of a radial artery, right?
Yeah, yeah, you can. I mean, it'll be delayed, right? Because again, as any distance or whatever from the point of impulse, you're going to have a slight time delay and then a pressure drop.
Yeah.
I think if it was me, I would probably transduce the balloon pump. And the only reason that we would need to do that is if there was a fiber optic failure, right? So if the fiber optic system fails for whatever reason, you can transduce that. It used to be when I like one of my first balloon pump transports ever, we hooked up both, and that was the policy where I worked. And so we did a fiber optic, and we also hooked an arterial line to that transducer. And we never recorded both numbers. Both sets of numbers were never different from each other. So, as I think more people got comfortable with the fiber optic stuff, I think we just kind of dropped transducing that line.
Hmm.
Uh, but if you only had one hookup, I would transduce the balloon pump so that you get the most accurate numbers right at the tip of the balloon, and you can check on timing a little bit better that way than you would. Your timing is going to be a little bit more accurate the closer you are to the balloon. That's why I would do it.
Yeah, and I mean, primarily it's going to be going off of your ECG, right? So like
Yes, hopefully. Yeah.
if something were to happen, but if you needed to, all right. Yeah, it's just a weird question I had. I also had one like,
Yeah.
all right, here's the other one. So let's say you do have to connect to that one,
hmm
um, and you get your transducer all set up, and you're going to attach it. So if you just take that cap off, are you going to get some blood coming back off of that?
You will likely have, if it's capped, you're likely going to
Yeah.
have some arterial blood coming out of there. It's all it is a sheath all the way to the tip of the balloon. Um, and so when we place the balloons in the OR or in the cath lab or whatever, if they're listening to the perfusionist, they're supposed to fill that with some saline or crystalloid solution, something that is not going to coagulate.
Hmm.
Because if that backfills with blood and it's not being transduced and not being moved, then that blood inside that sheath is going to clot.
That's what I was
So
wondering. Yeah.
yeah, yeah. So ideally, what you would do is do this at the bedside, before you transport with somebody who's intimately familiar with the balloon pumps and knows, how to flush that sheath with a crystalloid solution. And then at that point, you can, and I would not recommend trying to do that on your own without any kind of experience because that goes straight into the ascending aorta. So if you end up with a little bit of air or something like that in there, that's bad for the patient. Um, so yeah, you really, if you're going to transduce it, and it's not already hooked up to a pressure line, it needs to kind of be done by somebody who is very familiar and comfortable with doing that.
And you said it was bad to have air in the aorta. Why is that? I can't even get it out. I was going to try to say it serious. All right, dude. Let's end it there. We're going to go
All right.
sidetracking real quick.
Yeah.
All right. Thanks, man. Is there anything else we're forgetting about?
I mean, I could talk about balloon pumps all day, but I think this is a great primer for it, for what diastolic augmentation is and why it's important in these patients with these lesions and knocked out LVs. So I think it's good. I'm happy.
Awesome. You the man. Thanks, buddy.
No worries. Have a good one.